All right. Well, welcome everybody to this installment of the Health Museum's presentation of Parents, Let's Talk About Mental Health with the Menninger Clinic. My name is Andrea Strohmeyer. I am a science educator over at the Health Museum, and we are so excited to have everybody on today and have Dr. Rose on from Menninger Clinic. A few reminders about today's session. This is being recorded, so it will be on our YouTube channel in a couple of weeks or so for everyone to go back and replay. I know I personally will be replaying it. I'm very excited about this topic personally. And also as a reminder, please leave your videos off. If you have any questions, there is a Q&A box down on the right-hand corner of your Zoom panel. So you are welcome to type your questions in and we will get those over to Dr. Rose at the end of this session. We also have the chat box on, so if you have anything you'd like to add there, you are welcome to do it. All right, so I'm going to hand the conversation over to Becky Seabrook. She is our absolute rock star Senior Director of Guest Engagement.
Thank you so much, Andrea, and welcome everyone. As Andrea mentioned, my name is Becky Seabrook, and I'm the Senior Director of Guest Engagement here at the Health Museum, and I'm very excited to welcome Dr. Mary Rose to this conversation. Improving the sleep of our children, and hopefully some hints for some of the parents as well. As a mom of 3, I can definitely relate, and I'm really looking forward to this conversation today. So I want to go ahead and introduce Dr. Mary Rose. She is a staff psychologist with Menninger's Sleep Medicine Service. With more than 25 years of experience in sleep science, Dr. Rose has been involved with numerous local, regional, and national presentations on this topic, and we are so happy to have her here today. Dr. Rose earned her doctorate from Virginia Consortium Program in Clinical Psychology and completed a postdoctoral fellowship at the University of Texas Medical Branch, Galveston. She is the president of the Southern Sleep Society and is a member of the Texas Psychological Association, Behavioral Sleep Medicine Society, and Sleep Research Society. She has over 30 published book chapters and peer-reviewed articles in journals such as Behavioral Sleep Medicine and Maternal and Child Health Journal. And in addition to her work at Menninger's Sleep Department, she's an associate professor in the Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine and an adjunct associate professor at MD Anderson. So Dr. Rose, thank you so much for joining us today. We're really excited to hear what you have to say. And at this time, I'm going to go ahead and turn it over to Dr. Rose for her presentation. And then after the presentation, we'll come back for a conversation on the topic and an opportunity for some Q&A. So Dr. Rose, again, thank you so much, and I'll hand it over.
Thank you, Becky. Hello, everybody. Hello, parents. I guess probably primarily parents. I want to talk about your children and sleep and recognizing major sleep disorders and things that we can do to try and improve our kids' sleep. One of the things I want to start with, get my slides to advance. My slides are not advancing. Whoops. Just give me 1 second. And apologize for that. Let's see if this is going to work now. Sorry, I'm suddenly having a problem with advancing my slides.
Dr. Rose, let's see, can you close the window and reopen them perhaps? Or what I can do is I can stop your share screen. Let's see, if I do that.
I can now advance them.
Okay, I stopped your share screen, so you now have the ability to share again.
Okay, second, let me go up here. Now I have to let me go over here. I apologize, everybody.
No worries. Do you see the share screen button at the bottom of your screen? At the bottom of the Zoom?
Yeah, but I got to go to the other, monitor and do it. So PC screen only. Let me do it this way. And then I'm going to go to my PC screen. Can you hear me still?
Mhm.
Okay, so, boy, this is very weird. Okay, 1 second. Children. And it says I'm screen sharing, so I don't really know what y'all are looking at. New share, maybe that will do it. I'm going to try that. One more thing. Okay, so I'm not sure what y'all can see, but I want to
Right now, we see sleep duration recommendations. So it looks
good.
like you're all
Okay,
set.
starting that one. Okay. So recommendations for preschool. Preschool is really where a lot of our kids sometimes start school. So I wanted to start at that age. And that's going to start with kids about 3 to 5 years old. So these are the national recommendations. National Sleep Foundation is really the go-to place for a lot of people for trying to know what these recommendations are for sleep. And however, there is a problem, which is that that's not really what kids get for sleep. And so what children tend to get for sleep is a much worse sleep schedule. So in middle school, kids have a significant sleep deprivation, about 57% insufficient sleep, 12% don't even get 6 hours of sleep per night on average in the United States. And high school students, this goes down even more, drops even further. And all studies that have been done with this, particularly the 2 major studies, showed that girls slept worse, both in middle school and in high school. And the reasons for that have not been very clear. There may be several different reasons for that in terms of like maybe obligations at home, et cetera, but they sleep very poorly. What's really important to know is that as kids get older, we know that they have different sleep needs. And so US teens lose at least 90 minutes of sleep every night from starting every year, when they start school. So as soon as they start high school, in the freshman, 90 years goes down until the 10th grade, 11th grade, et cetera. So they lose an enormous amount of sleep. And that is extremely problematic because they need a lot of sleep. So I wanted to do a true false before I really get going. And again, I'm not sure if you all can see what these questions are, but you can think about the answers to these yourselves. Becky or Andrea, can you see the slides now?
Yes, I can. It's the true or false slide.
Yay. Okay.
You're perfect.
So, yay. So with structure, and this is an infant question, but it's important because a lot of us have infants while we have smaller children too. Structure of infants can be put on a night routine. So with structure, they can be put on a night routine. And I ask this question because a lot of parents think that they can just make their infant go on a nighttime routine. And as we talk about sleeping kids, I'll talk more about circadian rhythm and the fact that kids, when they're little, aren't just day night like we are. They need to sleep more frequently. So that's a big false. So infants are really free running. So you got to let them sleep when they sleep. We usually will recommend parents try and take advantage of that and sleep when the child sleep when they can, since they're sleep deprived at night. With adequate sleep time is essential for memory consolidation. That's a big yes, because we know that during REM sleep, a lot of our memory consolidation happens. This is why when students sleep after they study, they actually do better on performing on exams than if they had slept and lost all that extra time from studying. They'll do more poorly. You would think that extra time of studying would increase their performance, but it doesn't, actually decreases it. And there's a relationship between individual sleep need and school performance. This one is a huge false. And I think a lot of people have some myths that, people who sleep very short times are geniuses, or you have to be tough and not sleep, and that makes you a better physician, et cetera. And that's really not true. There's no relationship that's ever been established between how much sleep a particular individual needs and whether or not, and what their intelligence level is. Children from socioeconomically disadvantaged homes sleep less than their same age peers. I think that's a really important question, because what we've noticed in a lot of research is that is absolutely not. Oh, that one is true. That one's true because the way I worded it. That is true. So children who have more economically disadvantaged homes have an enormous problem with their sleep. They sleep far less, they have more fragmented sleep, And there's probably a variety of reasons for that, which we'll get into when we talk more about general sleep in children. But largely, safety is a huge factor. And children who are in disadvantaged areas are going to feel less safe. They have more obligations. They have more transportation time that they have to spend trying to get to and from school, et cetera. And this one, sorry, bounces in. Those are bouncing when they shouldn't. Okay. So true or false? Children can catch up on sleep loss during the week by extending sleep on weekends. That's false. So we do this a lot, and you may have seen, and I know at least one of the questions asked about their teenager coming in and sleeping, like coming in from school and then crashing, or sleeping on weekends late and being unable to drag them out of bed. And that's really associated with sleep deprivation that is so very common in teenagers. So they never really catch up. You never really catch up on sleep debt. So damage that's done from losing sleep isn't something you just simply reverse. It's a very important, extremely important that children sleep the amount of time that they need. They can never really catch up. About 10% of motor vehicle accidents are due to drowsy driving, of which people between the ages of 16 and 24 account for more than 50%. That is an amazing true. So meaning that 10% of all motor vehicles, according to the Department of Transportation, are drowsy driving related, and 50% of those are in kids. And it's disproportionate for those between like 16 and 20 also. And a lot of these accidents are happening when they're driving to school. Snoring when sleepy is normal in children. No, it is not normal. A lot of the time we think that it's cute or that it's a normal thing, but any kind of snoring is resistance in the airway. So when you hear that in your child, it may be a sign of other problems that we want to make sure that we identify. Later school start times are linked with a significant decrease in motor vehicle accidents and higher GPAs. That's a huge true, and that's very interesting. School start times have changed, particularly with teenagers and with high schools in many cities now, starting off in Rhode Island, where one of the major researchers, Mary Carstaiden, works. And she has done a lot of research on teens and drowsy driving and on teens and GPA. And we know for sure GPAs across the board tend to go up when children are able to sleep more by being able to get up later. And next question, it's normal to fall asleep when bored. False, it's not. So when we're bored, we're kind of fatigued, we're worn out, we're not happy, and we're annoyed, but we're not sleepy. So when people fall asleep, when they're bored, they're opportunistic. They're just sleeping because they can. And they can have the resilience when it's not in a dark room, they're not in a boring meeting, et cetera, to get their reserve up and prevent falling asleep. But when they are bored, it's very difficult. So they just give into it, to that sleep drive. Teens and adults have similar sleep needs, but teens go to bed in Western cultures primarily due to technology. This one's kind of a tricky one. So it's false in the sense that we know that technology is causing a lot of problems because kids in Western cultures particularly have a lot more technology and they tend to be on social media. But teens and adults have very different sleep needs. And teenagers really need a great deal more sleep than adults do. So the impact of of sleep loss and the physical impact is generally weight gain. We know that for adults too, increased risk for diabetes, particularly in adults. But immune challenge, we found a lot of what's called cytokines, the links that tell us about your immune challenges and your ability to ward off illnesses is very decreased if you are sleep deprived. Pain sensitivity is also, there have been many studies that show that people are more susceptible to pain when they have inadequate sleep, poor recovery from exercise and injury, poor athletic performance, and motor vehicle accidents. And I keep stressing motor vehicle accidents because it's very correctable if we can get school start times to change for kids and get them a little more sleep. So impact of sleep that is psychological. And this is the big place where I think Menninger really shines in our practices. Irritability, I think we all know that from kids. It's a very common one. And particularly with younger kids, you really see them start to really act up. Poor grade performance, and we see children falling asleep. It's not just because they fall asleep in the classroom, but because, and they miss things, but because they can't focus, they can't concentrate, and their system is not working right. They're not consolidating memory, that things have learned very well. I think this is a really interesting one. And they found in a couple studies, lack of intellectual curiosity, which is different than IQ and is different than grade performance, but it's enthusiasm for things. And children who are sleep deprived start to become less enthusiastic. And control problems, kids cannot stay calm. They cannot get their control over their emotions when they're sleep deprived, and they really kind of melt down more. And I think as parents, again, we know this too. Attention deficit hyperactivity I have here in bold because we see this a lot in children. And one of the first things we do when we see this is we try and make sure that sleep apnea isn't present. And that's one of the big sleep disorders. It's very, very easy to diagnose, and we'll talk about. But children who have sleep apnea that's untreated look exactly like ADHD. It's very hard to differentiate it. Many neuropsychologists, in fact, will try, if they have any indication that the child may have that, to try and get that ruled out before they will recommend treatments for children with attention deficit symptoms. Changes in adolescence that are really important to recognize are there's a biological phase delay, so there are circadian rhythm. We all have a circadian rhythm. This is why we feel better at some times of the day and worse at some times during of the day. And when we wake up, we generally have more energy because our sleep debt is low, but it's the hardest thing you can do of the day is wake up. You have a cortisol surge and it really puts a lot of pressure on your system, and you're making this giant transition into wakefulness to start the day. So we know that this is a huge factor, but kids really have major changes that make their sleep different than when they were little kids and then what they will be as adults. Melatonin, which is a major hormone that is produced by our brains. A lot of you probably know about the medication melatonin, is produced later than it is in adulthood. That means the kids get sleepier later and they want to sleep later. Dr. Cascaden had also found in her research that a lot of children were driving to school with melatonin levels that were equivalent to what their parents' melatonin levels were in the middle of the night when they were still asleep. And again, probably adding to not just the sleep loss, but that change in the timing and the poor timing that we make adolescents go to school, contributing to their increased motor vehicle accidents. And there's also really dramatic decline in slow wave sleep. Slow wave sleep is a stage at which little kids produce a lot of the growth hormone and they have a lot of the changes. And so that deep sleep also starts to lessen. It's not as good as it was when they were littler children. Sleep challenges for adolescents, natural biological phase delay, which we know happens across the board, whether they're in a Western culture or not. Enter the earlier school start times, particularly in high school. And for some reason, a lot of the times we will start schools in high school even earlier than we do the junior schools for some reason. Later activities in sports. I've had teenagers who had their sports activities were before school, starting at like 6 a.m., which is, again, if you think about that melatonin output, it's appalling to think that a child is going to be able to start doing gymnastics at 6 a.m. and then go to school is very misdirected. And sports, so they do other activities, they do sports. Some of them have work. They care for younger siblings. They have social media entrapments. That's an entrapment, though. That's not an obligation. And they have huge hormonal changes, as all of you know who've had teenagers, massive changes. And they have to drive to school. So all of these are massive changes. And the big one is that you got to remember, too, is there was a study was done looking at their work. Their work week is basically a 60-hour work week of the average teenager. And a lot of us work 50 hours, some of us work 60 hours, and some of us work less, but that's a lot for an adolescent. But that's pretty much what their schedules come down to for their obligations. Impact of sleep loss, again, for teenagers. And I don't know how many of you know this. This is a quote lifted from Disney, Encanto. And those of you who have smaller children have known, and over the past few weeks, you've heard this song over and over and over and over. Right? I'm a strong one. I'm not nervous. I'm as tough as the crust of the earth is. And it goes down, and it turns out she's talking about, I'm your sister. I'm stronger. See if she can hang on a little longer. Who am I if I can't carry it all, if I falter? And I like this because I know a lot of parents think about this song and they think that's me, but I think it really depicts a lot of what teenagers probably feel with regard to their sleep and balancing everything that they go through. Sleep and psychiatric concerns. So major depressive disorder is almost always about 75% of people with major depressive disorder have insomnia, and about 25% have hypersomnia. That hypersomnia increases as kids get a little bit older into older adolescence. And this is important too. The caregivers of kids who have poor sleep are much more likely to have depression, distress, marital conflict. And children who have poor sleep are louder. They can be screaming in the night, wandering in the night, fighting, going to sleep. And then the parents who may already have little precious time are trying to help and understand their child. And so it causes many problems in the family in general. Other thing that we look at a lot at Menninger is suicide, because we have many adolescents in our adolescent unit who have attempted suicide or thought about suicide. We have to really understand that is a huge epidemic in this country. And it is secondary only to unintentional injury in children and adolescents. And we know that it's also associated, we know that for sure that, we know that suicide is also antagonized by lack of sleep, suicidal thoughts and suicide attempts. So how do family lifestyles impact children's sleep? Family lifestyle can be simple things, which I think a lot of you know. Sleep environment, TVs in the bedroom, light, noise, parent shift work. And this is an important one too, because when parents come in and out, they come in at night, late at night, it can wake kids or kids feel uneasy, unsafe, etc. Parents have to break up the parental duties in the daytime. And sometimes I've had parents who are doing shift work come home from work and drive the children to school, which is an extremely dangerous thing I try to discourage people from doing, because that's when you're really your worst and not alert. Siblings with sleep issues, safety concerns. We talked about lower socioeconomic. When children don't feel safe, it's instinctive and evolutionary to not sleep well because you don't feel like you can. You don't feel like you're going to be able to well. Late meals, again, sometimes we get very delayed with everything, and then children with reflux disorder or who are going to get jazzed up with desserts, etc., that can be very hard for them to sleep. Co-sleeping, again, some parents will co-sleep, and that's something that's completely up to a parent to decide what they want to do. But children will go in and out of rooms, and that can create a pattern where parents are so tired and kids will wander from their room into a parent's room. So sometimes they'll sleep here, sometimes they'll sleep there. And we've seen families before where the whole family is kind of wandering around the house looking for a place to sleep that's comfortable because they've gotten into these terrible patterns. And routine. So if there's a lack of routine, I think we all know that's the number one thing that we see a lot of the time for children's behavior and for their sleep. Diet, sugary foods, etc., can be an issue. It's not studied that much for its effect on sleep, but we know that when children, particularly special needs children, have too much sugar on board, that it can be very difficult for them to sleep. And electronics. Electronics has been kind of touted as the great antagonist of sleep problems for adolescents. It is a problem, and blue light is, but a bigger problem is probably us as parents not providing an environment where we remove the electronics and have that put in another room at night, and also where we set limits on that and teach our children the importance of good sleep, because no one really knows what other people do with regard to sleep, because people aren't sure what they're doing for sleep. They guesstimate, but many people will say, oh, I'm fine on 6 hours, because our judgment is not very good with that. We think we're okay, we're not. Temperature, so temperature in the house. So one thing I want you to think about for a minute is how you set your temperature. Now, the electric company a while back had some kind of a program where they said, okay, go ahead and set your temperatures really high at night, and then you can save money. Well, it turns out what we really need is about 65, 66 degrees for optimal sleeping. So when people are hot, and this happens particularly with anybody who is older, has major medical problems, or teenagers, they get very hot and then they wake up all night and they don't regulate the body temperature well. So we want to be cool, really cool at night to sleep. So I want to talk about sleep disorders a little bit. I'm not going to talk about apnea and some other things very much because I want to get back to some of the psychological components of sleep that we need to focus on. But how do you recognize these things for your kids? There's sleep apnea. So sleep apnea is major markers for that is going to be snoring. Interestingly enough, bedwetting is also a big marker for that. And many of our adults who have sleep apnea that's untreated actually wet the bed too. It's just they cannot get up. Their sleep is so disrupted that they are stopping breathing all night and they can't even get out of bed to use the bathroom. And their system is not working very well. They wake with dry mouth because they're kind of trying to suck air in during the night. Sleepwalking. So anything that makes your sleep disrupted is going to cause, anything that causes airway problems so that your sleep is fragmented all night can lead to these other kinds of disorders. Like sleepwalking, falling asleep in school, teeth grinding, talking in sleep, thrashing around, all of those things are also a sign of potential airway problem. You grind your teeth to try and open your airway, you talk in your sleep to try and open your airway, you thrash around to try and wake up. And the same thing with just kind of sleepwalking is that your system doesn't want to get up, your body doesn't want to get up, but you also, you can't wake up, but you also, can't sleep properly. Attention deficit, again, I talked about that a little while ago. All of these symptoms, a lot of the symptoms that we have in attention deficit, lack of concentration and focus, falling asleep all the time in school, fighting irritability, all of those things can be a symptom of actually sleep apnea. So sleepwalking is a really important one for kids, not as much so in adults because adults don't experience it as much. But sleepwalking occurs in deep sleep, slow wave sleep. Some people think that REM is deep sleep, but it's not, it's slow wave sleep. It can cause injury, and there have been many children very badly injured. So we want to really recognize that if your child has those symptoms. It can be worsened by sleep deprivation or sedating medications. The sedating medications, again, the person doesn't really wake up, but their body is still in that slow wave sleep and when they will walk. Sleepwalkers don't remember events. It's not like nightmares. And they can have very complex behaviors too. They can leave the house. Now, sleepwalking often resolves with age, but in adolescents I've seen who had it, still had sleepwalking. We have to be careful because, again, sedating medications, alcohol, any of that can make it worse. And actually, young males are more likely to have violent behavior in their sleepwalking than females, and they can get injured, punch walls, etc. Night terrors, different from nightmares. Night terrors tend to be very fearful wakings that are characterized by screaming and just unable to get up. They will, that also occurs in deep sleep. They'll scream suddenly. And the really hard part about that for families is that it will happen shortly after the child goes to sleep, and it's a blood curdling scream. And I know that there's at least one or two of you who've had children who've done that. And it means the whole family wakes up. You cannot console the child. They may be thrashing, hitting, etc. And they don't remember it. They have no memory of night terror events. So how do we really listen to our kids? How do we look at them and understand what's going on in their minds and what's happening with them and the importance of identifying what's going on with their sleep and how it impacts them? So insomnia is the big one that we deal with. Nightmares and insomnia at Menninger for kids. Insomnia is also called insomnia of childhood or sleep, and there's also sleep refusal. So your child won't go to bed. They cannot fall asleep. They won't go to sleep. They make excuses to fall asleep. They avoid coming, or they come out of their room repeatedly with different excuses, or they go into the parents' room. There's crying and a lot of resisting of bedtime. And I'll talk about treatment for those things in a little while and the causes. Recognizing nightmares. Nightmares are very frightening dreams, terrifying dreams, which wake the dreamer. And that's the difference between nightmares and night terrors. They're common in children, very common in middle school. They're antagonized by scary movies, loss, grief, trauma, certainly, and anxiety. And we see in our trauma patients and our mood disorder patients, nightmares is a huge problem. So trauma is not always cause nightmares, but it is a symptom of nightmare, nightmares are a symptom of trauma. But nightmares can certainly be independent of trauma. And they can be, to some degree, a normal developmental experience, but not when they're frequent and intense. But they are a marker so I'm backing up a little bit with this, they are a marker for suicide risk when they are very prominent and they are frequent, particularly in older children and adolescents. So we do have to pay attention to them. We know in adults, it is a big marker for suicide risk. We cannot just pass it off as something that will go away or just something that can't be dealt with, because we do have treatments for nightmares, and it is something that's serious for mental health. So what can you do? So there are a lot of things you can do. There's create routine for your children. I think all of you probably know that one. Providing support and structure for your kids is really important. And support is to recognize that they have different sleep needs and changing sleep needs, and what kind of cues they need from you to help them to meet their needs. Quiet time for the whole house at night. And I think this is a tough one, but having the whole house kind of quiet down at a certain hour not only demonstrates for your kids the importance of that and the importance of wind down, but it also means that your child won't be woken by people like laughing or playing games, etc. So that they also don't feel kind of excluded. They feel like this is a family thing, everybody sleeps at night. Prioritizing your after school activities so kids don't get ever overextended, because I think that's a huge problem with children these days. Avoiding sleep delays on weekends and holidays. And this is a hard one because on weekends and holidays, we tend to go to bed a lot later, right? So we want to avoid that because then it throws you off for the next day for school. Providing safety, of course, support school start time changes, no electronics in the bedroom, or put things on silent mode if you can. I think that's very helpful. But we know that adolescents tend to keep their phone and their electronics within reaching distance and not on silent mode, much more so than adults do, particularly older adults, to completely turn them off. So our Menninger sleep program, we have a 2-bed sleep lab. We see patients for insomnia, sleep apnea, sleepwalking, kicking, nightmares, sleep refusal, childhood. And we're really ideal for those who have more complex psychiatric histories and who are also having these other disorders. But we see patients, all sorts of patients for the gamut of sleep disorders. What we do in a lab is we do a study overnight, look at sleep of the child. We look at sleep apnea, periodic limb movement, and that's sleep apnea is literally cessation of breathing. So what we want to do is make sure that your children can breathe properly when they sleep at night. We look at limb movement disorders, so disruptive kicking in sleep, sleepwalking. So that again, we try and rule out any other problem with that. Nocturnal seizures, which can sometimes children are having those and not in the daytime. So looking at their EEG just quickly in the day will not tell someone. We have to look at what happens when they go through deep sleep if they're having problems with seizure disorder. Therapies that we use often are for insomnia. For even younger kids, we can do cognitive behavioral therapy, and it's extremely effective, and it is a standard of care for adults, and it works very well for children. Promoting routine and giving parents support so parents understand what to expect and what is developmentally normal, and setting up structure to try and help their kids succeed. Nightmares, we use a technique called imagery rehearsal training. It's really effective. And it works very well with children. We use it in veterans. It's one of the standard of cares that we use for people with trauma. And it can be used also for people who do not have trauma. And so I've used that frequently in children as young as about 8, and it's highly effective. Environmental modifications, of course, regarding safety and making the child not feel uneasy, not watching scary movies, etc. Circadian rhythm disorder is something that we often see in teenagers. And again, if you think about what I talked about earlier about their phase shift that they need, they're 2 hours delayed for when they want to sleep. So, I mean, advanced for when they want to sleep. So they want to go to bed later. They want to get up later. So we can sometimes use light in the morning to really get them going. We can keep them out of the bed when they're not sleeping, try and give them structure. And those are extremely important things. I'm not going to talk too much about medication either because I'm not a psychiatrist, but there are sometimes medications that will help with circadian rhythm disorders too. We use that with shift workers. Obstructive sleep apnea, we're going to do tonsillectomy. There's some common tonsillectomy and get out the adenoids works really well for kids when they snore, although some children need positive airway pressure. Sleepwalking, again, we know sleep restriction. If your child is a sleepwalker, when they don't sleep well, or enough time or sleep well, they're gonna definitely sleepwalk. So you've got to be careful of that. Alarms on the door, safety proofing the room. So if they fall out of bed or come out of the bed, that they don't hit their head on anything. That becomes really essential. And enuresis is another problem that we see often with kids again. And what we want to do is keep, really make it so that children have self-efficacy, right? That they know it's no shame, there's normalization. It could be caused by sleep apnea. It can be caused by a lot of different things, and they generally grow out of it. But we don't want them to be shamed because it's out of their control. Sometimes scheduled wakings work as well, and they work very well. So you wake the child just a short while after they wake up, after they go to sleep, and then you have them use the bathroom. Because enuresis also comes out, or peeing the bed also comes out of slow wave sleep. That works really well because that's in the earlier part of the morning that your child will usually end up wetting the bed. So in summary, there really aren't any absolutes. Every family and their child is different. So, please listen to your child, provide support, and ask questions. And that asking questions piece is a really important thing. And that will help you get started with recognizing what's happening with them. Are they not going to bed? Are they resisting bed because they have nightmares? What are their nightmares about? What happens in them? Why do they think they have them, et cetera? And why are they falling asleep during the day? And what's happening at night, et cetera? So those are really important questions for your children. And set routine, but don't be so rigid. It always has to be the exact same because that's too much pressure for you or for your children. And teach your kids how to budget their time. Reduce pressure on them because we know that kids start to build and build and build with that pressure. And I know it's difficult because sometimes they're not doing things they should do, particularly teenagers, but we pile on a lot of pressure. It makes it harder for them too, to be able to find that time to sleep and give themselves permission to do that. And encourage later start times in high schools because it's very important that we try and do that to accommodate them. We know it has a massive impact on them. So I wanted to put out a few references here. I like this. This is really for infants, this Oliver Berkman quote, but I really like it because I think it applies to anyone who's a parent. Every baffled parent goes searching for answers and manuals, but what they really offer is a reassuring fantasy that most difficult questions have one right answer. There's no one right answer for you and your family with sleep, but we do know kids in general aren't getting enough of it. And we have to find ways to make sure they understand its importance just as they do their diets and everything else that they do. But it is an essential thing and we cannot live without it. And we really do need to try and improve their sleep. There's some other references here. I love Jody Mandel and Judith Owens up here, Pediatric Sleep. That's why I put that book there. The CDC has great resources, National Sleep Foundation, American Academy of Sleep Medicine, and the American Academy of Pediatrics all have some very good resources. So thank you very much. And I want to open up to questions now. And I appreciate all of you listening, dealing with my many foibles with the computer when we got started.
Thank you so much, Dr. Rose. It's an incredible information, and no problem. I think we've all been through it in terms of some of the virtual quirks where everything is working, then all of a sudden it's not. So anyway, that's not a problem. But this has been a fascinating presentation, and for those that are joining us this afternoon, if you do have questions, you can go ahead and put them in the question box. I encourage you to do that. Though we've also had some questions that came in ahead of time before the program. And so I'd love to talk about some of those now. One of the questions that we had that came in is there a right time to go to sleep and to wake up? And it sounds like that depends on age. You were talking about with some of the adolescents, it tends to be later. So is there, what is the answer for that?
It's adolescents need to go to bed later because that's what their system is telling them to do. It's what their whole biology is set up to do. There's no exact time, but we know if you're trying to get the amount of time that you need for kids, then you have to think about when do they need to get up and go backwards from that to find that time. There's no, you can always make someone stay up later, but you can't make them fall asleep, right? You can't make them fall asleep, and you can get them up earlier. So with your teenagers, you want to try and get them up a little bit earlier to keep that regular schedule on weekends because they're trying to phase extend to catch up, but then they wake up at noon or 2 p.m. and then they can't fall asleep again. So it makes it even worse. And we've seen teenagers actually kind of phase reverse. Like now they're just completely unable to be up in the day and they're wide awake at night.
And so for people, I think of, people that I know, people in my own family, certain people like to go to bed earlier at night and others are sort of night owls. And then there's the early birds and the people that like to sleep in. And is it correct to say that it's individual to some extent in terms of where a person's circadian rhythms hit, or why is it that some people need to go to bed earlier and wake up earlier and others, what is that all about?
It's unclear completely. There's a lot of different markers that we know that really drive that biologically. Largely evolutionarily, none of us are really night people, because we were designed to be awake in the day, hunting, foraging, etc., and to be in bed, asleep, or in a cave somewhere, if we're, evolutionarily, before the night things came out to hunt us. So there's no great answer to that, but there's some variation. And what completely controls that, we don't know. We know melatonin is a factor. We know there are a lot of different markers for that. And that's not my area of expertise, but some people feel really good when they wake up early and go to bed early, and an opposite way too.
Right. You mentioned melatonin, and you had mentioned melatonin during the presentation.
Yeah.
One of the questions that we got in, my 6-year-old son is on the spectrum, and it's very difficult for him to fall asleep at night. After years of really late nights, we tried melatonin and it really seems to help. Is there a downside to using melatonin with kids?
So I'm not a psychiatrist, but I will say that I've read a lot of the research on melatonin. So the biggest downfalls to melatonin is that there is a research, in fact, Judy Owens, who I just showed as a reference, had given a presentation a while back, a professional talk that indicated they tested a lot of the over-the-counter products for melatonin, and most of the melatonin was not mostly melatonin. It was mostly other stuff, which was outrageous. And so where you get your melatonin is very important. I can't recommend any particular product. I mean, I think she saw ones that were a little bit better than others. But melatonin, I don't know that it has a lot of downfalls. What you don't want to do is give huge doses. It tends to be at Menninger, I think our psychiatrists tend to give like maybe 1 to maybe 3 milligrams. The milligrammage that's sold in some stores of like 10 milligrams is way, 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 way overkill. And in fact, you can end up potentially with some damage to your receptors if you keep doing that. So we want to just have 1 to 3 milligrams. Ask your pediatrician, ask your doctor. But seeing a sleep professional with a child who has autism is not a bad idea, a pediatric sleep professional, because we know that those children have some of the worst sleep. And whether or not there's there's biological reasons for why they tend to be phase delayed, and they tend to have problems, and they tend to have more fragmented sleep. I don't know the answer to that, but we do see it. It's a very common problem in those children. And again, the parents, the wear and tear on parents is dramatic.
We have a question that has come in. All right, let me see. If space is limited, is it possible to have children sleeping in the same bed, but still have them get the sleep that they need? Is that feasible?
It's a good question. And, for always, until recently, there was a family bed, right? So, and in many countries, there still is, and there's co-sleeping still in other countries. And there's a comfort to that to some degree. I mean, the American Academy of Pediatrics is not keen on it because, particularly with infants, because there have been some events where people rolled over children, et cetera. But there's a natural instinct, again, for children, right, to have safety if there's an adult nearby. And this is probably why they sneak in, they kind of slither into the beds at night like snakes, and hope they won't get noticed when they're not supposed to be in there, because there is a huge comfort to having an adult nearby instinctively. I don't think there's a real problem with it unless one child is really kicking the other child, et cetera. You need to do what you need to do for your family. And I don't see where the problem will be with that, unless you've already identified another sleep disorder, or for some reason the pediatrician said there's danger with it.
And there's a follow-up question on a different topic. They're talking about the cognitive behavioral therapy. What does that look like? Is it a long process, and is it something that the parent can actually help the child with?
So CBT is usually, for insomnia, the focus on insomnia is usually about 6 to 8 sessions. And it's a matter of trying to identify, what are you thinking about at night? So there's a combination of things. You are trying to get the child to sleep when they're in bed. They're only sleeping. They're not doing all sorts of other things. And that you are also helping them understand, what are you thinking about at night? What keeps you awake? What kind of thoughts do you have? And then to start to identify those that aren't really functional or helpful for the child, and to have them see that, identify that, and then to try and replace those. So it's basically cognitive behavioral therapy in general, for those of you who are familiar with that. But it targets the insomnia and why the children can't sleep. But a lot of the time there are other things going on in the household that the child is not sleeping well because the environment, or the family's not sleeping well and people are wandering around the house, et cetera. So we want to look at the whole picture with the whole family to understand it better.
Yeah. And speaking of different issues that come up with children at night, there's a question on night terrors. Can you speak a little bit more about night terrors and what some of those triggers may be?
Yeah, so night terrors tend to be, those come out of slow wave sleep. And night terrors, I don't know if there's great evidence that night terrors themselves come out of trauma necessarily, but they are not completely developmentally abnormal. Some children will go through those if they have, particularly if they have other slow wave sleep problems. Like a lot of time I'll see people say, she has night terrors, she sleepwalks, she wets the bed. There's a combination of these things that go on. And during that slow wave sleep, we really are, we're out of it. I mean, we're just completely disconnected, and our brain, we don't have memory of things that go on during slow wave sleep. So sometimes there's medications just to help the child not go through that, to prevent injury, et cetera, and to give some kind of rest for the family that they will use. I'm not as familiar with how we treat that, because much more common is nightmares. And what medications are used for that. And it's a hard call for a family, because we hate medicating a child.
We've had a couple of questions come in about teens. One of them you actually addressed during the presentation. It was about the teens sleeping a lot on weekends.
Yeah.
But another question that came in, how do you tell the difference between teens that are sleeping a lot because they're tired and teens that are sleeping a lot because they're depressed? When is sleeping a sign of a possible problem?
Yeah, that's a good question. So I always ask people to think about the difference between fatigue and sleepiness, because those are two different things, right? So sleepiness is eyes heavy, falling asleep, drifting off, peaceful. Fatigue is burned out, like zoned out, burned out. I can't take this cognitively, emotionally, physically, et cetera anymore. That's different. So when a teen is withdrawing, like not wanting to be with anyone, that's different than when they're sleepy. If they're falling asleep a lot, they're probably sleep deprived. If they're just checking out, then we've got more of a problem with depression. However, you also want to recognize if there's a dramatic change in your teenager with their sleep pattern, you do want to ask questions about why they think that is and be alert.
One of the questions that we have is it possible to get enough sleep but not enough quality sleep? And it sounds like you've been talking a little bit about that with some of those things that may be happening during the night.
Right. Absolutely. Because we will see people, and in fact, we'll see people who their sleep study shows that they had very normal sleep, but they don't feel like that. So a lot of things happen in our brains that are different types of electrical activity that can happen that is more like wake or unrestfulness, but our sleep, it looks like a stage of sleep, but there are other things in there that also look like wakefulness or alertness. So if you think about it, that alone can be problematic. But even with someone with apnea, they may have sleep that looks fine for their total sleep time. But if you are waking every, few minutes, unable to breathe, yes, you're going to have very unrestful sleep, because then you've got all these other things going on in your system. You've got cortisol and your heart's racing and your adrenaline's going. And so, yes, then that's going to feel very unrefreshed.
Very different.
Yeah.
Very
Yeah.
unrested.
Yeah.
Another question's about something going on in the night. This one is on nightmares. Do children or adolescents grow out of nightmares? Is it possible that they grow out of them?
They did, it's interesting. Yes, absolutely. So I don't want to be too alarmist. I want people to recognize that it's an important thing to talk with your child about. But particularly in adolescence, where we're also seeing anxiety, depression, and we see nightmares too, then we really, really want to be alert. But a lot of children do. Nightmares are not uncommon in children. I doubt that there's anyone on this call whose child has never had a nightmare of any sort. I mean, they will have, they may not seem like nightmares to me. It's kind of like, I dream the Easter bunny, this or that, but they're nightmares for the child. They scare them. And they do often grow out of them. So kids' brains are trying to make sense of the world around them. And there are so many things too that we don't even realize. What are they thinking? Your children will say things and you're like, where did that come from? Because we don't always know how they're misconstruing something or interpreting something wrong. So their brain is trying to make sense of all of that. So they have more nightmares, they have more anxieties, and they do tend to grow out. Boys who are about age 10 is probably the highest hit for nightmares. So it's that group that usually has the most nightmares.
There is a question that has come in about stress and anxiety. I think we can all relate to being in a period where there's quite a bit of stress and anxiety about any number of things. And this question is looking at, does this stress and anxiety disrupt sleep? And if you have an elementary age child and are trying to help them process that to get better sleep, what kinds of questions can you ask them?
So yes, anxiety and stress absolutely interfere with sleep. And that's, as we know that as adults too, right? That's a major factor for cause for insomnia. So I ask them what they think is going on in their sleep. I'd ask if there's anything that's been bothering them, like at school or at home. And I use a lot of open-ended questions, and so usually depending on if they're elementary age school age children, then I would say, when you're playing with them, when you're doing other things with them, things will come out that they'll reveal about their anxieties or stressors, and listen to them, because sometimes, they're just chattering and we're just like, but they're actually telling us something about something that's been provocative for them. So it's important to recognize those cues.
You had mentioned insomnia, and there was a question that came up about, it seems like every other person I talk to is struggling with insomnia. Is it increasing? What causes it? And what do you do about it?
So insomnia is a condition in which you really, you have difficulty falling asleep, staying asleep, etc. Early morning wakes, unable to get back to sleep. Children, it's usually difficulty falling or staying asleep, usually falling asleep. So I think that with COVID and the lockdowns, it's been very hard for people. There've been a lot of difficulty that people have had adjusting. We know that adolescents actually have had like the hardest time of any age group. And that's probably because their kind of developmental and social trajectory was changed, right? When they were pulled out of school and away from their friends. But insomnia is very, very common. At least 10% of the population experiences significant insomnia. And we don't know how to wind down, and we never turn off. So that's not even an issue, because our brains keep going, but we really need to learn to wind down to be able to give ourselves permission to take that pressure off. So I think what happens is we're used to saying, I'm going to do this at this time and this at that time, and it's all scheduled for us. And then not sleep though. You get into bed, it's dark, it's quiet, no distractions, your partner's asleep. You can't sleep. Because all of the stuff that you did not deal with earlier in the day is definitely going to come after you if you didn't deal with it in the daytime. So that's largely kind of in a nutshell, I think, what happens to us with insomnia. There could be many causes for it, medical, et cetera, but the reason why so many people suffer from it is it's not compatible with the schedule we want. It's an activity that we have to be relaxed for. We can't make it happen. We can't force it to happen any more than we can force being happy.
We could just figure out how to turn our minds off
turn the wind down.
Right.
Not off, but to learning how to identify what's the stuff that's going to come get me tonight.
Right.
I can't sleep well, or I'm not sleeping well. And then also permission that, I'm not always going to sleep well. And seems to be that I'm still functioning during the day. I'm getting things done. I don't like it, but I'm still functioning. So you don't catastrophizing it. And then you start to anticipate, oh, it's going to be a bad night. Oh, I'm not going to sleep tonight. And then that creates a self-fulfilling prophecy.
Right.
Yeah.
One of the questions that we got has to do with caffeine.
Yes.
I guess it would be when we're not getting enough sleep, or when we're sleeping in the mornings, whether it's energy drinks or sodas or coffees or things. The question was, how much caffeine is too much caffeine, and is it possible to be immune to caffeine?
So there's variability. It depends on if you have any medical conditions with caffeine. The average person reports drinking about 200 milligrams, which is about 2 cups of coffee a day. But again, we're not always, it's like if you ask people what they ate, right? It's not always, completely accurate. So I'm guessing people tend to consume a little bit more than that. So I think that it depends. I know that for sure, if you're drinking like 6, 8, 1,000 milligrams, that's pretty high. And caffeine does a lot of things. It can constrict your blood vessels. And then when you come off it, you can have rebound and you can have headaches, and it can impair wound recovery, et cetera. So for sleep, though, what happens is you're trying to fight off sleepiness, and it can stay in your system for a long time. And so long after, you think it was out of your system, it's still in your system, fragmenting your sleep. So it's kind of an individual thing, but we almost all of us use caffeine and to get us through the day, but probably what we need is more sleep.
Right. Yeah, and it's interesting that it stays in the system long after we think it would be. So I think just being maybe very cognizant of when we stop drinking caffeine throughout the day is an important piece.
Right. And it can cause a crash too.
Right.
It comes out of our system. Yeah.
And let me see, I think we had one last question. This one had to do with the sleep study. What happens during a sleep study? And you did talk a bit about the types of things that you look for during the sleep study. Can you talk a little bit about what someone can expect during a sleep study? And I think that will be our last question today.
Okay. So during a sleep study, what we do is first we want to identify what's going on with the child, so we know exactly when we do the sleep study what we want to look at. And then when it's a smaller child, we can have a parent sleep in the room with the child. That's sometimes a little tricky, usually in a chair, because we don't want to hear the parent snoring. We want to be able to hear the child. So, and if the parent has a sleep problem, it's undiagnosed, that's a problem. So the child will put sensors on their head, we'll put, sensors on their legs, et cetera, a little pulse oximetry. And then they sleep there overnight, they fall asleep, and then the technician can see them and hear them during the night. And then in the morning, we let them go home, 6, 7 a.m. And then our physician will read the study to determine whether or not we saw any airway problems, if we saw kicking in their sleep, if we saw seizure disorder, any of that.
Very interesting.
Good.
Dr. Rose, it is amazing, but the hour is up, and I want to thank you so very much for taking the time to meet with us today. This has been a great topic. Andrea, did you want to go ahead and wrap for us today?
Yes, absolutely. Thank you so much again to Dr. Mary Rose for talking to us about children's sleep. I learned a lot. I hope everybody else did too. And please join us for next month's Parents Let's Talk About Mental Health with Menninger on Thursday, February 10th, right here at noon, for Asian Americans and addictive behaviors, what no one wants to talk about, with Dr. Trong. You can also see more information about the Menninger programs at our website. I will drop that in the chat here momentarily. And thank you everyone for joining us today.